Hello, everyone. My name is Lauren Snellings, and I'm the Research Director at Voices for Virginia's Children. Today, I'm going to be giving an overview of child well-being and equitable research practices. Before I begin the presentation, I would like to take a moment to share about what our organization does and why we are positioned to do this work. At Voices for Virginia's Children, we help all children in Virginia thrive, but particularly the most vulnerable. We are Virginia's only statewide multi-issue advocacy organization for children and youth. The topic areas we cover include early care and education, family economic security, foster care and adoption, health and well-being, mental health, and trauma-informed care. We are privately funded, nonprofit, and also nonpartisan, so we work with both Republicans and Democrats when advocating for children. The other unique thing about us is we are data informed. By looking at the numbers and trends to identify what children need, and then we use that to inform our advocacy around policy decisions. In addition to the work in the previous topic areas that we do, we are also home to the Kids Count Data Center. In partnership with the Annie E. Casey Foundation, we house hundreds of indicators of child health and well-being at both the state and locality level. We have data on child demographics, economic well-being, education, family and community, health, safety, and so much more. We also track these indicators over time and have the ability to disaggregate many of these data points by race. I consider myself a data nerd, but I work with people of all data skills. So if you're a data nerd like me, or maybe even a data phobe, but want to know more about the health and well-being of children look like in your community, please reach out to me, use me as a resource. I can do custom data polls, talk you through data points, presentations, or even create custom community profiles. Now that I've talked a little bit about our organization and the work that we do, I want to start the presentation off with some explanation of how we at Voices describe, examine, and measure child health and well-being. Typically, our organization looks at population-level data instead of individual-level data to describe what's happening to Virginia's children. This means that the data is typically secondary and we don't collect the data ourselves. Data serves many different purposes to describe, inform, educate, and persuade others to take action on today's most important topics. We can use these points to track progress, identify trends, evaluate impact, determine barriers, and expose disparities. Data can be a great tool. However, it is not the final answer. Data typically helps us ask more questions about what's happening in a community and often does not provide us with any direct answers. The data that Voices for Virginia's Children uses to inform our policy work and incorporate into the Kids Count Data Center come from many different places. We use data from the census and other online sources such as Feeding America or the Employment Commission, but we also get data directly from state agencies here in Virginia. We have worked to develop relationships with places like the Virginia Department of Health or the Virginia Department of Social Services and even the Department of Education to get communities and organizations access to data that they may not have known about or been able to access before. So I really like this graphic explaining the social determinants of health. You don't need to pay too close attention to it, but first look at the right half of your screen. Historically, we have associated health with the absence of disease and good behaviors. We're moving away from this downstream approach to more of an upstream approach, recognizing that things outside of healthcare influence our health, some before we're even born. We know that social inequities, such as race and gender, can influence our health, but we also know that institutional inequities, like certain policies and laws, can even influence our health. And even living conditions such as housing, employment, and education. We recognize all of these things as the social determinants of health. And an individual's health is also influenced by both their community, their environment, and society, which is why we look to population level data in these areas. Traditionally, we think about children's health and well-being in different domains. The physical health is known, but there are also other significant domains such as safety, environment, and mental health, all of which we collect data on and can be found on the Kids Count Data Center. We also know that realistically, children have different starting points and opportunities in these domains. Across the nation, gaps in health are large, persistent, and increasing, many of them caused by barriers set up at all levels of our society. After all, it's hard to be healthy without access to good jobs and schools, safe, affordable homes. Health equity means increasing opportunities for everyone to live the healthiest life possible, no matter who we are, where we live, or how much money we make. Equality is sameness, equity is fairness. But in order to know if we have equity, we need to be able to measure and compare with data. I really like this graphic from the Robert Wood Johnson Foundation that visualizes the difference between equity and equality. The top picture is representation of equality, in which every individual is given the same type of bike. The bottom picture now represents the concept of equity, in which every individual is given what they need to be successful. The child is given a size-appropriate bike, the larger male is given a larger bike to suit his stature, and the woman in the wheelchair is given a bike that is custom to her needs. I also really enjoy this graphic. The first picture represents inequality, in which only one child is receiving a fallen apple, representing unequal access to opportunity. The next picture represents equality, in which both children are given the same ladder to reach the tree. The tools and assistance are evenly distributed, but still the children are both not receiving what they need. The third picture represents equity, in which both children receive custom tools that address the inequality. One receiving a taller ladder than the other so they can reach the apple. But my favorite picture is the last one representing justice. Proactively straightening the tree, fixing the system to offer equal access to both tools and opportunities before equity is even needed. Next, I want to talk about the difference between health disparities and health inequities. Health disparities is when different groups have different health outcomes, such as infant mortality or life expectancy. But health inequities is when different groups have different access to resources, such as education, food, housing, and healthcare. Health equity seeks to eliminate health disparities that are based on social factors or demographics, such as race, by delivering resources in the amount and manner that is necessary to meet the needs of the individual, the family, and the community. Health disparities should be considered within the context of health inequities in the practice and policies that embody and reflect racism. As I said before, in order to determine where we are coming at with an issue with equity, we need to be able to measure and compare with data. However, data is meaningless if we do not provide context and insights into what it means. That's why it's important as child advocates who care about the well-being of all children to look at subpopulations to make sure that, in fact, all children are doing well. It is important that we look at data for subpopulations who often have trends that are masked by larger groups to make sure that resources are spent to those who need it most. However, people are often afraid that if we break down data, that the differences will result in blame put on the families instead of where it should be, on the structures that have shaped the outcome. One of the primary health inequities that causes poor health outcomes for Black people is the denial of access to health care because of political choices made by our state leaders. One of the most impactful ways to examine this for a lay audience is the difference in life expectancy. County Health Rankings and the Center on Society and Health has done numerous studies and research into this topic in Richmond, Virginia. There are outstanding differences in years between many groups. In Virginia, the life expectancy is about 79.4 years. But if we drill down smaller to Richmond City, this decreases to about 77.2 years. But not everyone in Richmond City has that opportunity to live to 77. Some populations, such as white or Hispanic ethnicities, can expect to live to 82 years or almost 89 years respectively. However, Blacks can only expect to live to 73 years. Looking into even smaller geographies, those living within Richmond even have a different opportunity to live to 77. Within Richmond, those living just a few miles apart can have as much as a 23-year life expectancy difference, ranging from 63 years in Gilpin Court to 83 years in Westover Hills. There are countless historic and current practices and policies that have perpetuated systemic racism and the oppression of Black people in this country, one of which is redlining. Much of the differences in life expectancy across Richmond City can be tracked back to specific place-based policies. For example, look at this map of redlining in Richmond City from many decades ago. Redlining, which was a process in which lenders systematically denied mortgage loans to people of color for certain neighborhoods, which was an official policy at many banks through 1968. This discriminatory practice led to increased residential segregation in many cities. These government programs also created a segregation, disinvestment, and wealth gap that still exists today and can be seen in the life expectancy map. To avoid inequitable practices and policy, Voices for Virginia's Children uses a data-informed approach to our policy setting agenda. First, we analyze data on child health and well-being. Then we identify where all children need help. Next, we use these results to inform policymakers and then advocates for the policies and follow up to ensure equitable success. Now that I've gone over our process and values at Voices, let's take a look at how children in Virginia are doing. In Virginia, about 1 in 5 people are children. We have nearly 2 million children who reside within our Commonwealth. The majority of children in Virginia today are white, non-Hispanic, about 54%. There are just over 377,000 Black children, followed by 247,000 Latino children, 122,000 Asian or Pacific Islander children, and over 100,000 children who are 2 or more races. Over the last 16 years, from 2000 to 2016, there's been a 10% increase in the number of children of color that has led to a near even split between the children of color and white children in the Commonwealth. Children who are Latino or 2 or more races lead the pack in the shifting child population here in Virginia. This increasing diversity of child population means we need to consider what opportunities and potential policy solutions exist for all children to develop into healthy, productive adults who will support and drive our economy. Next, I would like to look at economic opportunity. When discussing poverty, we look to the federal poverty level. For a family of 4 in 2017, the federal poverty level was $24,600. When we discuss economic disadvantage, we say double this, or 200% of the federal poverty level, at $49,200. So in 2017, about 32% of children were living on a family income of just over $49,000. As you can see, these numbers have not changed in over a decade. 1 in 3 children in the Commonwealth are economically disadvantaged. And when we look at these numbers disaggregated by race, we see extreme disparities. The yellow line down the middle represents 32% of all Virginia children I just mentioned. As you can see, 2 race groups are significantly higher than this. 53% of Black children and 46% of Latinx children are economically disadvantaged. Another example of showing why it is so important to look at subpopulations for data. Next, let's look at short-term suspensions. Short-term suspensions are defined as removal of a student from school for 10 or fewer days in an academic school year. In Virginia, between 2018 and 2019, almost 70,000 students were issued out of school suspension, which has been increasing over the years. In addition, students of color were disproportionately suspended. Black students were 3 times as likely to receive short-term suspension than their white peers. However, research shows that they do not commit offenses more commonly than their peers. The civil rights data collection finds youth of color not only face harsher discipline than white students, they are more often referred to law enforcement and are more likely to be taught by lower paid and less experienced teachers. Students who are suspended from schools are more likely to receive academic failure in the future, mental health problems, substance abuse, gang activity, and be involved in the justice system. This is an example of a data point where you don't just want to report the numbers, but help the audience interpret what they mean and the causes. For example, if you have data on racial disparities in school suspensions, but no studies to understand how the disparities are produced, your audience could misinterpret this as Black students are more likely to commit offenses that cause a suspension instead of how the research clearly shows how suspension and expulsion policies themselves and the manner in which they are applied contribute to the disparities in school expulsions. Now let's look at adverse childhood experiences. An adverse childhood experience includes separation from a parent for reasons such as death or incarceration, physical or emotional abuse, living or experiencing domestic violence, parental substance abuse, mental illness, or community violence, and economic hardship. In Virginia, according to the National Survey of Children's Health, about 20% of children, or 1 in 5 kids, have experienced at least 2 of these. Now let's look at this data by race. Similar to our other data points we reviewed, children of color were more likely than their white peers to experience 2 or more adverse childhood experiences. While 15% of white children said they experienced at least 2 ACEs, 18% of Hispanic children and 37% of Black children experienced 2 or more ACEs. Findings from the National Institute Studies of Child Abuse and Neglect have found no relationship between race and the incidence of child maltreatment. Instead, incidence of child abuse and neglect was associated with poverty, single parenthood, and other related factors from economic well-being and social economic. It is possible that child welfare professionals involved with a case or family may knowingly or unknowingly let personal biases affect their decision-making in these processes. Next, we will look at low birth weight. 2 trends point to racial disparities evident in birth: a higher percentage of Black babies born low birth weight and a higher rate of maternal mortality for Black mothers than for the other races. In Virginia, Black babies are twice as likely than non-Hispanic white babies to be born low birth weight or below 5.5 pounds. All children of color are more likely than white babies to be born low birth weight. Another example where you want to add context to the data: among many researchers, attention has been shifting from individual level causes of poor birth outcomes, such as negative health behaviors, to the causes of those causes, the social, political, economic, and cultural forces that shape disease risk in populations and provide the context within which individuals function. Stress, racism, and neighborhood environments are just some of the contextual factors that researchers have been looking into. Now let's look at foster care. Children of color are disproportionately represented in care and more likely to be placed in group settings. These disproportionate needs of children and families of color are particularly due to the higher rates of poverty. However, some research also shows that there may be racial biases and discriminations exhibited by individuals serving these children, such as caseworkers, mandated reporters, and others. There's also child welfare system factors that can contribute to these disparities, such as lack of resources for families of color. To learn more, please check out the community chat, Racism and the Foster Care System, Where Do We Go From Here, led by policy analyst Allison Gilbreth. So now that we have reviewed data on child health and well-being in Virginia, let's discuss some best practices for integrating data equity into our work. The first best practice is to use a racial equity lens for presentations involving data whenever possible. Researchers should disaggregate data by subgroups, such as race, nativity, country of origin, to uncover the heterogeneity of experiences both between and within groups, and to look at the structural and social determinants that might explain these observed findings. Also consider using asset-focused indicators. Asset-focused indicators make it easier not to stigmatize families or individuals for shortcomings. Indicators framed from an asset point of view become aspirations. Closing the gap for those who aren't faring well fulfills an aspiration. For example, it's easier to get people to think about economic barriers when the indicator is percent families with sufficient income to raise children, rather than when the indicator is percent children living in poverty. We also need to recognize the cultural variation of indicators. Some routine indicators for which data are regularly collected apply differently to families of color than their white counterparts. For example, indicators on child care may focus exclusively on licensed centers and registered family care providers. Yet families of color are disproportionately more likely to rely on families, friends, and neighbors for informal childcare than their white peers. For data that shows disparities, disproportionality across racial and ethnic groups, what are the likely causes of these disparities? In addition to disaggregating data, it is also important for us to think through the indicators that we are displaying. We need to have an understanding of the structural causes of any significant disparity in proportionality that the disaggregated data show. Indicators that are structural, system-focused, policy-oriented, or programmatic in nature, such as the percent insured or children in foster care, will train the reader's eye on places where policy or programs change can be focused. Indicators that are individual in nature, such as children test scores, can incline the reader to default to individualistic explanations for problems that exist, such as lack of parental support for kids' performance. Also, when selecting indicators, think about the framing of disparities that leads with structural causes and try to always bundle solutions with the problem. For example, when showing graduation rates by school and racial groups, it may be equally important to show the financial resources provided to each school, the local history of school segregation, or the financial hardships faced by students and families. Finally, when selecting indicators, think about your comparison group. Researchers typically make comparisons to white outcomes when they examine disparities. Such comparisons reflect the assumption that white outcomes are the standard and that communities of color should aim to achieve that standard. These comparisons also apply positive values to cultural norms associated with whiteness and negatively measure people of color by those norms. When integrating data equity into our work, we as researchers need to examine our own biases. We strive to be objective and neutral in our research. However, backgrounds and experiences may affect the way in which we conduct research. We need to reflect on our own backgrounds, experiences, and privilege when we undertake and interpret our data. It doesn't just stop at disaggregating data. We must also understand the root cause of these inequities. All policies, programs, and practices have some impact on equity. Consider using a racial equity impact analysis to examine how policies, programs, and practices impact who is affected. Finally, I wanted to share a list of resources you can use or follow up on from this presentation. This is not by any means a comprehensive list, but intended as a starter to help you understand using race equity lenses in our work. If you have another source that you find helpful, please send it my way. Finally, please keep in contact with Voices. Please sign up to receive emails and advocacy alerts at virginiavakids.org. Also, click on the Trauma tab to learn more about our campaign for a trauma-informed Virginia. We also invite you to follow us on Facebook, Twitter, Instagram at VA Kids. We look forward to connecting with all of you. Finally, please keep in contact. Please sign up to receive emails and advocacy alerts at vakids.org. Also, click the Trauma tab to learn more about our campaign for a trauma-informed Virginia. I look forward to communicating and collaborating with you. If you have any questions or data needs, please feel free to contact me, Lauren Snellings, at lauren@vakids.org. Thank you.